Hello and welcome. In this video, we'll be discussing diseases of the mouth. Note that for any segment of the GI tract, one can name the most important cause of congenital abnormalities, acute inflammatory abnormalities including infections, degenerative and autoimmune diseases, and neoplasia. And if you do this for each segment of the GI tract, mouth, esophagus, stomach, and so on, then you can master the disease quite easily based on this simple and effective organization. In the mouth, the most important congenital defect is the cleft lip and palate. This is a malformation. It results from a failure of fusion of the midline structures of the face. Most cleft lips and palates are due to a sporadic abnormality. But if it is identified early by screening ultrasound, then it has a significant association with underlying syndromes. And these are mostly neuroectodermal in origin. 50% of clefts will involve both the lip and the palate. A word on embryologic terms. A malformation is a primary or intrinsic defect of formation, and it implies that there is abnormal signaling of cells forming an organ. By comparison, deformations are secondary, meaning they are extrinsic. The organ is normally formed, and then an outside abnormality causes a defect. A good example of this would be a hip dislocation in delivery. A disruption refers to a breakdown of a normally formed structure. And realistically, there's only one cause of this. This is amniotic bands. A sequence refers to multiple defects arising from a single pathology. And the only significant example of this is the Potter sequence of renal agenesis and oligohydramnios. Agenesis refers to the failure of an organ to form. A good example of this would be in 22q11ds deletion syndrome, in which there is aplasia of the parathyroid glands. The commonest presentation of cleft lip and palate is by antenatal screening by ultrasound. The soft tissues of the face and neck are visible by the second trimester. It is part of ultrasound screening to do an examination of the upper lip. If an abnormality is found, then search for an underlying syndrome will reveal a neuroectodermal defect in about 30% of cases, and if these are severe enough, then termination of the pregnancy can be considered. Note that in the family of non-invasive prenatal testing, ultrasound is good at visualizing malformations. When one goes looking for chromosomal defects, though, the older techniques include the quad testing of alpha-fetoprotein, estriol, inhibin P, and beta-HCG, and this is being replaced by cell-free DNA, in which 10% of a blood draw consists of DNA from the fetus. Cleft palates become clinically significant in countries in which there's not good medical support, because one needs the ability to suckle for proper milk letdown. When the infant latches on to the nipple and creates a strong sucking force, this sends a neurologic signal to the hypothalamus, corpus callosum, fornix, optic chiasma, pituitary gland, foramen of Monro, thalamus, and hypothalamus. And in the hypothalamus, the signal goes to two different nuclei. The paraventricular nucleus will produce the oxytocin, which is released from the posterior pituitary, and the arcuate nucleus will stop producing dopamine, which is inhibitory, and that will allow for the release of prolactin. In the milk-producing lobule of the breast, these will act on two different cells. The ductal cells produce the milk, and the myoepithelial cells contract so that the milk is expressed. Oxytocin acts on the myoepithelial cells, and prolactin stimulates milk production from the ductal cells. Suckling mostly is due to an intact palate, and so the disease tends to be less severe if there is only a lip defect. Complications from cleft palate include otitis media due to abnormalities of the eustachian tube and abnormal speech. Treatment is surgical, typically of the lip at 3 months and of the palate at 6 months. The most important infectious conditions are associated in patients that have HIV-related disease. We'll present these by their clinical manifestation. The first of these shows the presentation of white plaques along the side of the tongue, and this is characteristic of hairy leukoplakia. Its significance is that it is one of the first manifestations of HIV infection before it actually presents with AIDS. It is due to a reactivation of EBV virus. Early in the AIDS epidemic, before there was good serologic testing, this was an important finding, and often HIV-infected patients were diagnosed by dentists, but now it's been replaced by good serologic screening. A second characteristic infection of immunosuppression is oral candidiasis. Candida albicans walks the line between opportunistic infection and normal flora. It's often found in normal people who develop the infection when they have minor changes such as treatment with antibiotics, pregnancy, or the development of diabetes. It also is common in any patient with immunosuppression from any cause. If the diagnosis needs to be confirmed by testing, one can actually do a scraping of the lesion and see the small yeast with a pseudo bud from it. The underlying principle of the gross appearance is the difference between a membrane and a pseudomembrane. A true membrane is an epithelium, whereas a pseudomembrane represents the necrotic debris of an ulcer base. This means that pseudomembranes can be wiped off, leaving the ulcer basin often with a small amount of punctate bleeding. By comparison, an epithelium of a true membrane does not wipe off with gauze. This is an example of an aphthous ulcer, which is often called a canker. These occur spontaneously in normal people, but they're much commoner in people who are immunosuppressed. They are of unknown etiology, and explanations have varied as widely as infections versus autoimmune disease. They are benign and self-limited, and there's no good data on any treatment being more effective than any other, so it tends to be symptomatic treatment for pain. When patients develop AIDS, they can get reactivation of herpes virus type 8, and this infects endothelial cells, causing Kaposi sarcoma. This is a tumor in which one sees proliferation of small endothelial channels filled with blood in open spaces, and this then gives a reddish blush to the gross appearance. And as the tumor progresses, it can go from macule to papule to nodule as the tumor grows. As with all diseases in AIDS, treatment depends on the underlying immune system, and restoring immune function is the key to treatment. Kaposi sarcoma can occur in any organ, often seen on the skin, but they can occur in internal organs as well if one does imaging. There are a number of diseases that have characteristic findings in the mouth. In this example, we see prominent lentigines, or freckles, and this is characteristic of Peutz-Jeghers syndrome. This is a disease in which there is loss of function of a tumor suppressor. These patients have an 80% lifetime risk of developing a cancer typically of a ductal organ. Before they get cancers, they often develop hamartomatous polyps of the gut. These are premalignancies, and so patients with Peutz-Jeghers require screening colonoscopies and removal of the polyps. A note on vocabulary. A hamartoma is any growth in which one has normal cells arranged with an abnormal architecture. A heterotopia, the synonym of which is ectopic or ectopia, is normal cells forming a normal tissue in an abnormal location. So gastric mucosa in a Meckel's diverticulum is a good example of ectopic or heterotopic tissue. An adenoma is a true benign neoplasm. The characteristic finding here is of small vascular structures in mucocutaneous areas, and this is characteristic of hereditary hemorrhagic telangiectasia, which went by the eponym of Weber-Rondo-Osler disease. This is an autosomal disease in which abnormal TGF-beta results in the formation of abnormal vascular remodeling. This gives two different abnormal vascular structures. There is the formation of AV malformations, and these are found in the lung and in the liver, and then the telangiectasias, and these are small, thin-walled vascular structures that are mucocutaneous. Diagnosis of this disease is established by finding 3 of 4 of the following findings. Epistaxis. This is due to the telangiectasias of the nose, and they're most commonly seen in childhood. Iron deficiency due to blood loss in the gut, telangiectasias, and these can be seen on the physical exam, and then AV malformations. Because these form in the liver and lung, they have to be identified by imaging. And because this is an autosomal dominant disease, there often is a positive family history. Treatment of this disease is mostly about replacing iron from the blood loss in the gut and then risk of clotting and embolism from the AV malformations. This is a picture of a lower lip in which what the normal pink color of the lip is identified by the arrow. Therefore, the change in the remaining of the lip is one of hyperpigmentation. And this is a classic finding of chronic hypocortisolism, or the eponym Addison disease. More than 90% of these in America are due to a type 4 hypersensitivity autoimmune disease, and this gives a adrenalitis, meaning that the adrenal gland is destroyed by cell-mediated cytotoxic lymphocytes, and therefore with the usual adrenal axis of the hypothalamus to the pituitary and pituitary ACTH stimulating the adrenal gland with negative feedback from cortisol, that with the failure of the gland, one gets very high levels of ACTH. ACTH is produced in a complex protein development from POMC, and as this is broken down to form the ACTH, it also forms melanin-stimulating hormone. And ACTH and MSH both stimulate melanocytes to cause pigmentation over the whole body, most easily seen on the mucous membranes. This last picture is one that would be very rare to see nowadays, and what it shows is this bluish-gray line along the gums, called a lead line. And it's only seen with marked lead toxicity, so that would be an industrial exposure which would not be seen in the advanced economies of the world due to worker safety. So this is much more of a historical finding, and it's due to the fact that lead secreted in the saliva is broken down by bacteria to form a sulfide, and this sulfide has the characteristic gray-blue color that pigments the gums. The key autoimmune disease of the mouth is Sjogren's syndrome, a type 4 hypersensitivity disease of all exocrine glands. Every squamous mucosa has glands that produce serous fluid to keep it moist. These can be found in the vagina, in the esophagus, in addition to the lacrimal glands and salivary glands we associate with the disease. Patients will usually present with the symptoms of sicca, which refers to the dry eyes and mouth. There are high cytokine levels, as there are in any immune disease, and so they often have systemic constitutional symptoms of fatigue and malaise. The physical exam is non-contributory, and so the diagnosis is usually confirmed by testing, which can be showing positive antibodies. As with all autoimmune diseases, there's usually a positive ANA seen in 90% of cases, and then the antibodies specific to Sjogren's syndrome are Sjogren's syndrome A, or Rho, and Sjogren's syndrome B, also called LAW. The problem with these is they're only sensitive about 70% of the time, so for both to be positive is found in less than 50% of the patients. If there's difficulty diagnosing the disease, one can go looking for the cytotoxic lymphocyte destruction of an exocrine gland. And this is a minor salivary gland. More than 40% of the saliva in the mouth comes from a minor salivary gland. And if you run your tongue along your bottom lip, each of those little bumps is a minor salivary gland. So one can do a biopsy of the lip and show that there's lymphocytic infiltrate of the gland and destruction of the parenchyma. Sjogren's patients usually have a normal lifespan, and the major complications are a lymphoma due to the chronic inflammation in the glands, but also pulmonary fibrosis, which is seen in autoimmune systemic diseases. As a relatively benign disease, most of the treatment is symptomatic. Neoplasia in the mouth starts with leukoplakias and erythroplakias. Just as leuco is Latin for white and erythro is Latin for red, so these present as plaques or raised areas on the tongue or cheeks. Leukoplakia here, one can see, is a white plaque, and erythroplakia is red plaque. And one cannot tell by looking at these gross findings whether this is a hyperplasia or a dysplasia. Hyperplasia is a physiologic response. Now, it might have a pathologic stimulation like an irregular chipped tooth, but if you remove the irritant, it will resolve. Dysplasias, however, are pre-neoplasms, and so they only regress infrequently. The only way that one can differentiate them is by biopsy, and so any white or red plaque of the mouth demands biopsy. And the histologic feature of dysplasia is nuclear atypia. The most important cancer of the mouth is squamous cell carcinoma, and this goes under the broader heading of head and neck squamous cell carcinoma, which is written as HNSCC. This is a carcinoma, meaning it arises from an epithelium, and because the epithelium of the mouth is squamous, these are all squamous carcinomas. We can plot this on our universal timeline of carcinoma. When we start with risk factors, there really aren't any for squamous cell carcinoma of the mouth. Environmental risk factors fall into two very different factors. The first is going to be the carcinogens of alcohol and cigarette smoking. And this is a different disease than if it's due to the viral infection of human papillomavirus. In both instances, the early precancers form dysplasias, and these form progressively more abnormal epithelium as they accumulate the key mutations. More likely to be low grade is a leukoplakia, and more likely to be a carcinoma in situ is erythroplakia. And when the tumor develops the capacity to dissolve the type 4 collagen of the basement membrane, it will start to invade. And as with all carcinomas, there's lymphovascular invasion, and it then drains to the nearest lymph nodes, which are in the neck. And it's only after a long progression of spread to the lymph nodes that it then goes to systemic organs. And for the squamous cell carcinoma of the head and neck, this most commonly starts in the lung. When one comes to staging, T and M. The two different carcinogen families, the chemical carcinogens of alcohol and smoking, are most likely to form where there's the highest exposure. And so that's going to be right where they make first contact, which is right here. Alcohol and smoke tend to be found in the front of the side of the tongue or in the floor of the mouth. These are quite easily seen on physical exam. Viruses, however, have specific attachment proteins, and for HPV, this is going to be in the oropharynx. 50% of HPV-related squamous cell carcinomas will be on the tonsils, and these are hard to see in the physical exam. As well, they're not going to form symptoms because there's nothing to invade or obstruct. These are going to be two very different patterns of disease. The presentation is the usual of a cancer. First and foremost, they form a mass. And as that mass gets big and escapes its normal blood supply, the center breaks down and they ulcerate. The ulcer can either hurt or it can bleed. One can see here the rolled edges of the tumor where the cells have infiltrated, leading up to here, which is the ulcer. And in the bottom we see the white debris of the base of the ulcer. The best place to biopsy is right here because this is where one's going to find viable cells. The prognosis, as with all carcinomas, depends on staging, T and M. The tumor itself can be staged by gross exam and by imaging, but the lymph nodes can be done by palpation because they tend to be out in the neck. One has to know how the head and neck drains to lymph nodes. The first of these lymph nodes are here, the submental nodes, and they drain the front of the mouth and face. So these are going to be very important as draining nodes for the alcohol smoking cancers. The submandibulars drain the side of the face. The next critical group in cancer is the tonsillar, because this is where we're going to find the draining cancer cells from the human papillomavirus-related cancers. The superficial cervical nodes are much further down the line, and then these present as reasonably late nodal involvement. Here on the back of the scalp are the occipitals, and these drain the scalp. The last group is here in the supraclavicular area, and these are unique because this is very near to where the thoracic duct drains. These are the so-called Virchow's nodes, and they are important because they can manifest metastases from the upper GI tract, including stomach and pancreas. The treatment of head and neck squamous cell carcinomas is for the most part surgical. If they present late, and so they're not easily removed, one can shrink the tumors with radiation and chemotherapy, and this pre-treatment of a tumor prior to surgery is called neoadjuvant therapy. That brings us to the end of this tape. Thank you for your attention, and we'll see you in the next segment, which will be the esophagus.